We'll be moving on to the next segment of today's presentations. That is the college lecture. It will be supported by the Sidus Sunshine. And today's college speaker is Dr. Chamila Dalpadadu, consultant physician, senior lecturer in physiology, a special interest in geriatric medicine, member of the Australian and New Zealand Association of Geriatric Medicine. And of course, she's one of the co-secretaries of the Ceylon College of Physicians at this moment. So she'll be talking to us on his insight into autonomic dysfunction in older adults. Over to you, Chamila.
Thank you very much, sir, for that kind words of the introduction. In the next 25 minutes or so, I'll be taking you through the autonomic dysfunctions in older adults. And this would be my outline for the lecture. So we'll look at few patient histories and see what the differential diagnosis you can come up with for those patients' stories, I would say. And let's look at the aging and autonomic nervous system and the impact of autonomic dysfunction in older adults, and pathophysiology of autonomic dysfunction, the causes and the investigations, and some therapeutic highlights. So this is the first story. It's an 83-year-old patient with hypertension and dyslipidemia. He was feeling out of sorts when trying to walk after getting up from a chair for the past 6 weeks. So wife noticed that he seems quite disoriented and after standing up, and vacantly stares at her and has had near falls as well. So he has recent onset alteration of bowel habits and erectile dysfunction. Wife had noticed slurring of speech and slight weakness of the left arm of the same duration. So previously, before this incident, he has been very active, was traveling a lot, even overseas. And with this, he's very frustrated about the illness. So with this background, what do you think is going on? What do you think? Any guesses? What is the first thing you think of? Most common thing? Is it drug-induced postural hypotension? You see, must be on a lot of drugs for hypertension. It can be a cause. And maybe even absentiatious from the description. And obviously, he has features of right side CVA. And one might even think whether it's dementia, but this is of shorter duration. And autonomic dysfunction following CVA would be the most plausible explanation for his symptoms, I would say. We'll see, because there are other clinical features suggestive of autonomic dysfunction. Moving on to the second patient story. Sorry. A 65-year-old, rather young old person, a retired teacher living alone, was found at the floor of a room after a fall. She was conscious and rational, but was in severe pain with bruise over the right hip, probably had suffered a hip fracture. And in the background, she had diabetes and hypertension for the past 20 years and was on losartan and metformin. And recently, she has lost a lot of weight, loss of appetite, and complain of recent onset dry mouth, urinary retention, and constipation as well. So supine blood pressure was 124/64, and when she was propped up, the blood pressure dropped to 100/60. So definitely there's a postural hypotension, and we don't know whether that caused the fall, and it's a serious injury. So the possible causes leading to her fall, definitely orthostatic hypotension. We don't know the cause. It could be an episode of neurocardiogenic syncope, where the sudden failure of autonomic nervous system leading to vasodepressive hypertension and bradycardia, or even asystole resulting in loss of consciousness. We can even think of carotid sinus hypersensitivity, where there is a blood pressure drop as well. And this is usually following any sort of mimic to carotid sinus massage. So in both these patients, we could see there's evidence of autonomic dysfunction. And let's just look at what is there in the literature, as well as why it is so important in older adults. So the autonomic nervous system, I would say, is the one who controls how the devil dances, because it maintains homeostasis by regulating the function of immune system, heart, endocrine, exocrine glands, abdominal viscera, smooth muscles throughout the body. So this is a picture of a rookeder where it is quite evident if one of these strings break, he cannot dance. Same like the autonomic nervous system. If it fails, we are in trouble. So aging and autonomic nervous system, like all the other systems in the body, the autonomic dysfunction is associated with aging, and it's highly prevalent in frail older adults. So making matters even worse. And many clinical syndromes associated with older adults are due to inadequate or maladaptive autonomic responses due to physiological stressors. So advancing age is a significant predictor of autonomic dysfunction. So severity of which increases with comorbidities like diabetes. And a study done in Bangladesh, in healthy older adults, the prevalence of autonomic dysfunction was high as 23.34%. And in rural India, it's a mixed cohort, healthy and with comorbidities, but it was very high as 73.8%. And of course, you all can just imagine with use of drugs such as antihypertensives, opioids, SSRIs, and other drugs may worsen this picture of autonomic function and increase the morbidity. So let's look at the impact of autonomic dysfunction in older adults, because it is not just affecting the cardiovascular system, but all the systems in the body. And first thing what we see is the postural hypertension. Clinical evidence, simple test which you can check, and they may even come up with those symptoms. And falls, like our patient, certain patient, falls and poor mobility. And of course, this recurrent orthostatic hypotension and hypoperfusion has been linked to vascular dementia. And it affects the sweating, so hypo or anhidrosis. So they cannot tolerate heat, and this pseudomotor dysfunction lead to heat stress, and people probably dying of heat stroke. And of course, in shock, if there is septic shock, they cannot mount that catecholamine response, and they would die of multi-organ failure. And of course, the biggest silent killer would be the cardiac morbidity and mortality. The cardiac autonomic neuropathy has been linked to sudden cardiac death due to arrhythmias. And poor quality of life due to most of these, plus bladder and bowel dysfunction and sexual dysfunction. Unless we probe into these problems, they might not come up with these symptoms. So what is the pathophysiology? Now, autonomic ganglia would not change in number with aging. But aging is associated with dendritic alterations, changes in synaptic function, and neuroaxonal dystrophy. And the normal synaptic turnover is exaggerated, producing excess swelling and sprout formation. And there's excess neurofilament glycosylation and phosphorylation. So especially this is seen in diabetes. As you know, in our society, what we see, the postural hypertension, autonomic dysfunction, the majority have diabetes. So if they're old, so double burden. And these cellular processes diminish the synaptic transmission, reduce end-organ innervation, and overall functionality of autonomic nervous system. So this is the summary of the pathophysiology, I have just mentioned of what is happening to the aging autonomic nervous system. So if we look at the second patient who had a fall and had definite evidence of orthostatic hypotension, the first patient's symptoms are also may relate to orthostatic hypotension with the history. You can divide the causes into two categories, either neurogenic or cardiovascular. So neurogenic causes also, whether it could be a central or a peripheral autonomic dysfunction. So central causes would be the primary autonomic degenerative disorders, which I'll come to in a little while. And the cardiovascular, impaired diastolic filling, reduced stroke volume, and preload. So obviously, this category is related to drugs, cardiac failure, and dehydration. So if we look at the pathophysiology of postural hypertension, there's loss of alpha-1 mediated vasoconstriction and reduced baroreceptor sensitivity, and reduced levels of all these hormones, renin-angiotensin, aldosterone, and elevated AMP. So why am I talking about all this is because therapy is targeted in reversing some of or modulating some of these mechanisms in order to manage the symptoms. And of course, impaired diastolic cardiac filling and stiffened ventricles are also implicated because it leads to reduced stroke volume. So that is in cardiogenic orthostatic hypotension. So how do we assess? Now, autonomic nervous system innervates almost all the organs. So there should be a mechanism that we screen. Now, in your histories, like if you face your exam and if there's a patient whom you suspect there's an autonomic dysfunction, please go through the entire system of, you can go by one of these assessment systems, composite autonomic symptom score. If you can Google it and read it because the font is so small, you may not be able to read it. So it basically goes through all the symptoms of autonomic dysfunction pertaining to all the body systems. So there are other questionnaires as well. These are validated for research purpose. But you can get an idea when it comes to clinical assessment. So let's just look at some of the causes behind autonomic dysfunction. Now, the two patients whom we saw, we should be first assessing their symptom profile, examining, and then thinking of a possible cause for underlying possible autonomic neuropathy. Now, central disorders, multisystem atrophy, could be dementia with Lewy bodies, or Parkinson's disease is associated with the autonomic dysfunction, and there's an entity called PO autonomic failure as well. And after acute stroke, maybe our first patient would have had a stroke and now is suffering from autonomic dysfunction. It is prevalent up to 25 to 76% with acute stroke. So pathological damage to the insular cortex is associated with autonomic dysfunction. And of course, there are complex connections in the autonomic nervous system. So after stroke, it's so common. The peripheral disorders, we are very familiar with diabetes and any cause leading to amyloidosis, immune-mediated inflammatory neuropathies, neurotoxins, and with the recent COVID pandemic, we saw post-COVID dysautonomia as well. And of course, paraneoplastic. With the two patients, we saw the second patient, there was a pathological weight loss and loss of appetite. So maybe on top of diabetes, maybe this person is having a paraneoplastic syndrome. So those are the things we should look at when you are analyzing the cases. And some of the rare causes, as well as the postural orthostatic tachycardia syndrome, where the autonomic dysfunction is evident without loss of blood pressure or drop of blood pressure, there's purely tachycardia when standing up. So paraneoplastic autonomic neuropathy, these are the documented cancers, small cell lung cancer, tumors of the breast and ovary and lymphomas. And it has been well recognized in paraneoplastic associations like paraneoplastic autonomic gangliopathy and paraneoplastic sensory neuropathy, paraneoplastic encephalomyelin neuropathy, and Lambert-Eaton myasthenic syndrome. So how do we assess autonomic neuropathy? At the bedside, it will be your history and properly checking the orthostatic blood pressure drop. But we have to be very careful with older adults because they may fall when you're letting them stand up. So you have to support them. So in laboratory setup what we do in the Faculty of Medicine, University of Colombo at the Department of Physiology, we go by 5 criteria because we don't go by one single test. So the Zerving and Clark method uses these 5 methods. The heart rate response to Valsalva maneuver, heart rate variability during deep breathing, blood pressure response to sustained hand grip, then immediately after standing up, we check the heart rate response as well as blood pressure response. So when we look at the autonomic nervous system, as you all know, there's parasympathetic arm and the sympathetic arm. So out of these tests, deep breathing test, Valsalva ratio, and the orthostatic heart rate response primarily look at parasympathetic function, and the isometric hand grip and the orthostatic blood pressure would look at the sympathetic function. So I won't go through this because you all are very hungry. So this is the physiological basis of why we are doing all these 5 tests, because the heart rate changes. The beat-to-beat heart rate variability needs to be assessed. So what we do is we check the ECG, the beat-to-beat RR interval change and heart rate together with respiratory and blood pressure if available and the pulse rate. So with the hand grip test also, it's a beat-to-beat heart rate variations that we are looking at. And there are normative values that we check against. And in older adults, with regards to heart rate response to deep breathing, hand grip test, where we expect a blood pressure rise, that gradually decreases with age. And the Valsalva maneuver, there's, if you can remember your good old physiology days, you know the 4 phases and how the RR interval would change the heart rate and blood pressure. Now that ratio would decline with older adults. And the heart rate response to standing, we go by a measurement called 30 to 15 ratio. That also decreases with age. So that is due to old age. Now, the diagnostic criteria for autonomic neuropathy, we can either go by the Ewing's method, where if all tests are normal or borderline, it would be normal, but early would be one of the 3 tests. The heart rate tests are abnormal, and definite would be 2 heart rate tests are abnormal, and severe would be 2 heart tests and 1 or both blood pressure tests. The Bellevue criteria also look at the same kind of testing and test for deep breathing, Valsalva, and lying, and they would, categorize the cardiac autonomic neuropathy CAN into 3 stages. Now, there is another component that we look at, that is the heart rate variation. Now, if the resting ECG during the testing, we can look at the RR interval, and there is validated protocols, and according to the guidelines of the Task Force of European Society of Cardiology and North American Society of Pacing and Electrophysiology, there is frequency domain and time domain analysis, and we can fine tune and look at the sympathetic and parasympathetic nervous system. These are kind of the laboratory tests we can do to diagnose definitely whether there is autonomic neuropathy. And why should we be checking? Because we can, sort of say that this is part of old age. Why should you bother? But definitive diagnosis would be valuable in the management and excluding other differential diagnoses, like whether it's simply drug-induced or situational or, heart failure, like that. And in old adults, the parasympathetic dysfunction is found to be more than the sympathetic. And out of all those 5 tests, the deep breathing test has the highest sensitivity, and the orthostatic heart rate test had the highest specificity in evaluating the autonomic dysfunction in old adults. So it's kind of easy to perform because it's non-invasive, and although sometimes they might find it difficult to do the Valsalva maneuver, you can substitute with other tests, but obviously you have to, take precautions. So tilt test, now if somebody can tolerate the standing test, lying to standing, then you can proceed to head up tilt test, but which is contraindicated in severe ventricular outflow and mitral stenosis and known cerebrovascular disease, because that can induce, short periods of asystole. So we have to be cautious when doing head-up tilt tests, and we have to carefully select patients and precautions when getting the patient to stand up, even to check the postural blood pressure drop. So having done all that, say we diagnose, now what are we going to do about it? Now, like any, most of the degenerative neurological diseases, there is no cure, but there's a lot of things that we can do to improve their symptoms. We can ask them to increase their fluid intake and salt intake. These are simple lifestyle modifications. And of course, elevate the head end of the bed, because these symptoms are severe when getting up in the morning with a lot of lying down time. So we can reduce that effect by slightly elevating the head end of the bed. And we have to warn them when getting up on the morning to take some precautions. Ask them to take small meals. Why? Because after a heavy meals, obviously there's a lot of vasodilatory GI hormonal peptides, which would dilate the vessels, and that would exacerbate the blood pressure drop. And sometimes some people, now this is the probably only instance that you would prescribe coffee after meals, because it actually has an ability to constrict the blood vessels, planting circulation, and slightly increase the blood pressure so that the postprandial hypotension is minimized. Now these are off-label sort of indications. So the other maneuvers that somebody can do is standing with crossed legs. But it can be kind of difficult for a old person unless you train them, because muscle contraction will, increase the blood pressure by increasing the venous return, and thereby supplementing the, blood pressure rather than when there is severe orthostatic hypotension. So there are pharmacological and other non-pharmacological management apart from the lifestyle modifications, like the good old mineralocorticoid fluticasone that we usually use. It helps. And there are sympathomimetic drugs, ephedrine, midodrine, and droxidopa. Sometimes it's not freely available. And there are specific targeting drugs like octreotide, which increase the splanting and peripheral vascular resistance. Desmopressin would reduce the nocturia and get the patient to get some boost in the blood pressure, but with expense of hyponatremia and so on. So there are precautions or monitoring system, because most of these drugs will cause supine hypertension, which is unavoidable. And of course, erythropoietin is also used because it increases the blood pressure as a side effect. The non-pharmacological, the stockings, graded exercise and meditation. Now, a lot of evidence is there for graded exercise and meditation with no added side effects. There are 5 out of 6 star RCTs demonstrated positive effects of exercise training on heart rate variability. And meditation improves parasympathetic activity as evidenced by improvement in the Valsalva ratio. And it also improves the better regulation of the autonomic nervous system, as evidenced by EEG and functional neuroimaging. So there's a lot of evidence for these two not so expensive methods of management in treating autonomic neuropathy. Now, there are obviously other sets of advices that we should give, the things to avoid. So sudden head-up change should be avoided because that could, exacerbate postural hypertension. Prolonged recumbency after prolonged hospital stays, this would be exaggerated. And straining during micturition and defecation, and obviously exposure into high environmental temperatures, even hot baths, severe exertion, large meals, and alcohol and drugs with vasopressor properties. So those should be avoided when managing these patients. And we should be realistic in our goals, because complete normalization of blood pressure is not realistic, and supine hypertension should be, expected in these patients. And therapeutic goals should be symptomatic relief and improving quality of life. So this is one of the studies which showed definite, good outcome for exercise, graded exercise in managing the autonomic dysfunction. So in summary, aging is associated with the autonomic dysfunction, and it's worse with some of the comorbidities, and it results in clinical manifestation in several organ systems. And the value of investigating with simple non-invasive tests that are showed. And in older adults, the parasympathetic dysfunction appears to be more than the sympathetic dysfunction. And there are ways to manage these patients: lifestyle modifications, pharmacological and non-pharmacological, and of course, exercise and meditation, which is simple, effective, and inexpensive. So thank you for your patient listening, and thank you, CCP, for giving me the opportunity. So these are the references. So if there are any questions, you can either email. Yes, thank you.
Most of these elderly people are hypertension. Now, how would we select this patient to give that advice? Because other thing, the community physicians always say, cut down the salt.
Yes.
So,
Yeah.
how do you select this patient to give that advice?
Yes, that's an excellent question. Thank you. Because sometimes we kind of go to extremes when we are restricting diets in old adults. Now, I'm talking about, very old people who are frail, and their life expectancy may be, limited as well. So yes, salt should be restricted when you're managing hypertension. But in the same time, if they, fall and suffer a hip fracture, that could be the end of their lives. So it has to strike a balance. How severe their orthostatic hypertension, then your advice should be catered. And it's probably not added salt, but maybe the drinking enough water, or not just water, maybe, solutes filled liquids. Thank you.
Also, this the more difficult is the fact that the people with postural hypertension have postural hypertension as well. It's a nuisance to actually treat those patients. Your comments on how to treat these patients who often, if the entities that you mentioned on the left, we often see often with autonomic dysfunction.
Yeah.
And often we have this hypertension coupled with postural hypertension.
Yes, sometimes we kind of continue the antihypertensives in reduced doses, probably avoid diuretics, and coupled with fludrocortisone. But then you have to monitor the electrolytes, and sometimes our therapeutic goals may differ. You cannot achieve a nice, blood pressure control of, less than 140/90. Probably come to a compromise in that case. It all depends on how severe the symptoms are.
very high.
Yes, yes,
Yeah, high.
yes,
Then break up, they have the postural hypotension.
yes,
The morning their blood pressures are up.
yes,
During night, they are
very high. Yes. Yes, so some of these non-pharmacological methods like this head up tilt position and probably the stockings during daytime, those, because we usually just prescribe fludrocortisone and that's it. And the overall management is lacking in these patients and they suffer. Yeah, thank you.
Yes, Ramana?
Yeah.
Thank you, sir.
Thank you, Samala. Excellent. Going back, actually, this is the first, maybe I have never heard this lecture on autonomic dysfunction anywhere. College session, the young physician, maybe. It's something which has been listening. And if you ask why I am asking is, I am a proven autonomic patient. All the rest of possibly I know that she is doing that. The first case when we are talking, I have spent hours and hours with this people. Why? Because she doesn't believe in this autonomic dysfunction. Then I asked her, I didn't know that you will go to Navaloka and get it done. That is how I got to check all the tests were positive. And she said she has done it with you. The amount it causes to the problem, not to me, is the patient is from Australia. Their house in Sydney and their house in Colombo. And they have decided and they are traveling widely, as you said, traveling widely, and they have stopped going because of the scarcity, and now they from the nursing care, everything is cheaper here. They have decided to live in Colombo. So this amount of problem is because she wouldn't accept that this. So then I said it can be proven, and that is how you have done it. And that did not help her. She had gone back to the cardiologist, one of my great teachers, Mano, and he called me. So how I get, the amount of problem which causes is sometimes we don't. Everyone talks about only erectile dysfunction and fibroid, things like that, but there are so many cardiac problems. So excellent this thing I will enjoy. So I didn't know that you are doing, so there are plenty of patients to send to you.
Thank you so much. And I think with stroke, what you get probably gradually improves a little bit, isn't it?
And this particular person also, they are having a stroke, a diabetic stroke, I see it. But that was, to me, I have a feeling it is incidental because once the very first episode has occurred before the stroke, they were going on an escalator and there have been no falls. Actually, the cardiologist said Australia thought this is epilepsy and you wanted to do a what do you call this steady 24-hour EEG. So I said no, because they were going on an escalator. He was about to fall and somebody else has fallen, but there have been never a single fall. So it was all true. It looked like a hypotension which was causing it, but more than the problem, it is causing problem to the body. Thank you very much.
Thank you very much.
There's one question from one of the virtual participants. It's asking
If with a syncope, there's a patient is become very pale, does it mean that you can differentiate whether it's cardiogenic or neurogenic? Don't know. As a physiologist.
No,
Not.
yeah, it happens in both situations, so it's difficult to differentiate. So I think the history would be the key.
Okay, thank you very much, Shamila, for spending your time with us after a very hectic last few months and taking up this challenge, do this as well. So we have a certificate of appreciation. So we'll wind up for the today, and of course, following up Shamila's presentation, 2 weeks time we have the specialty update on geriatrics this month. So please join in for further on geriatrics. Thank you.